Audio's good.
I like it.
Don't break those, you
buffoon.
you buffoon.
I'm getting it.
Episode season 2.3. This is our Chadcast.
Chadcast.
Chad Stem Cell.
Chad GPT.
Yeah. Everybody say something all at once.
Meow.
This is a house of learned doctors. You're not a doctor.
Doctor?
Doctor?
Doctor!
Doctor.
Doctor?
Wait a minute, Doc. Are you telling me that you built a time machine?
I am a doctor. You're not a doctor.
Well, I think it's like it's funny, but also like you guys, you two, like what's the purpose of the addition with Chad? Like what was the origin story of that, and how long did it take?
Pure convenience.
Mm-hmm.
Yeah,
Well,
it's a large part of it. I mean, you've been a patient for a while, and I think we've just slowly gotten to know each other more and more. And then you guys probably started the conversation of you coming on.
Yeah, I mean, like a while ago, we kind of jokingly were like, gotta be nice to have, like, you should just come here once a month.
You might have used him a couple times on patients like, hey,
I literally called the one guy.
Yeah.
And you were on the phone in the room in the clinic, and then, I don't know, after that, you were kind of had your upset with your various clinic experiences, and I'm like, you should just work here. And I think that night you texted me and was like, Carla said I should do it. I'm like,
Yeah.
What do you mean Carla said you should do it?
Yeah.
So then here we are.
So it just flowered from there.
It flowered from there.
Blossomed.
Yeah.
But I think you enjoyed our practice.
Yeah. Well, and I think the addition of like Softwave and different things, right? Like there's a purpose for it, and it actually works. So, you know, I kind of saw the writing on the wall after a few years of doing this. Of eventually, I would have had my own practice, anyways.
Mm-hmm.
Is that common in your demographic as a clinician?
Especially for nurse practitioners, not so much PAs, because PAs have to function under
right.
an MD license.
We could have a whole podcast on like hierarchy of
licensure
and like what's going on with Alina and all their garbage.
But no, I think it is a natural progression. People get years of experience, and there's some state regulations where you have to have 2,080 hours of experience and like different things to open your own place.
Do you have that amount of experience?
Yeah,
Okay.
I have a couple hours more than that. But no, it's a natural progression. A lot of NPs do it, and it's not so much to go out and make more money. I think it's to provide better care of patients than what you see happens in an MD-driven clinic. And by no way am I bashing MDs, but if you look at NP-driven clinics where it's just nurse practitioners, they usually operate in the green for money, and they have better outcomes.
Why is that?
I think because NPs tend to spend more time with patients, and that's what it's all about, right? Listening to people's stories, gathering all of the information, and then coming up with a diagnosis or a treatment plan. Whereas physicians in college they're trained totally different, right? Yeah. And a lot of those practices, when you see MDs, they're told that they have to see someone every 15 minutes, right? Mm-hmm. Well, in 15 minutes, what are you assessing, or what are you actually getting out of that appointment? In my opinion, you're not getting much, right?
Is it a carrying capacity issue with just like the amount that those physicians are having to get paid, you know, like in a clinic setting?
So that's why the clinics do that, right?
Yeah.
Because they're paying these MDs
a lot of money.
Not so much primary care providers. They don't get paid the same amount, but these specialty providers, right? Like, you know, HEMOC doctors, for instance, out of school, hematology oncology, they come out of school, they're making $600,000 a year. Well, how many patients do you have to see to make that money back up in a clinic? It's quite a bit.
Right.
And so then how would you like to be an oncology patient with some type of cancer and go in and see a specialist for 15 minutes?
Right, and pay for it.
Because, you can't even really discuss all of the information that you want, nor do you feel like you're getting the care that you should get when you have a diagnosis of like cancer.
Yeah.
Mm-hmm. And it's awful, in my opinion, right? Like,
well, the poor clinicians too, I think they're overwhelmed with just the amount of volume of patients, and what do, you know?
And that's why you're seeing stuff in like you said, we could do a whole podcast on this, but that's why you're seeing a line of providers, threatening to strike. Essentia just
two
striked.
nurses that came in were like, I asked them, I'm like, is it a money thing? They're like, no, it's staffing.
Yeah.
Because they just can't handle capacity.
They can't handle
and then
capacity.
They're getting, what's her name? She said there's patients from that are sitting in beds for 4 hours post-op surgery and they can't even touch them because they don't like that. She's like, we're directed not even to give them food.
Yeah.
Because they can't sign off on stuff or clear them. They're just like observing them.
Well, and I'll tell you how big of a problem this is without getting too deep into the weeds about it. But when I was doing a particular job in neurosurgery, I'd go down to the ER to see a patient, and they were boarding patients down there for 1 to 2 days, where you're just sitting in a bed in a hallway.
Oh, God.
Because there's no beds or staff to take care of you up on the floor.
Was that COVID era?
Nope, that was recent.
Oh, gross.
So the Twin Cities hospitals are extremely busy, and one thing that people aren't talking about is there's less and less people going into the medical profession, right? Like medical school applications are down, nursing application are down. They're now paying nurses what NPs make just to get them in the door.
Right.
Right.
To keep
Like,
them, yeah.
yeah. So there's a big problem in the medical field, and it's only going to be compounded or made worse.
Yeah, it's going to be amplified with some stuff. Hopefully we can figure it out. But that's where you come in, too, because Zach can talk about it, but, like, you see a patient, they have something that's outside of our scope, and it's almost like pulling your nails out. It's like, go see your primary physician for this problem. And I had zero confidence that they were going to do it. Or like, go to a minute clinic and just get absolute. Right. I mean, I had my minute clinic experience. They didn't give me the right meds for my bronchitis.
Right.
And it just revved up again. And
It just got worse.
You're like, why'd they give you this?
No, and that's the problem, I think. You guys see so many patients that have not only spine issues or musculoskeletal issues, but they have tons of medications and they have a very complex medical history.
Which we can't touch.
You can't speak to it.
Nor do I want to,
right.
Honestly.
And so it works out great that I'm literally 20 feet down the hall, right? And usually my schedule is fairly open to where people can get in quite fast.
Well, it's been nice how accessible you are. Hey, Chad, come in here. Talk to this person for 5 minutes.
Yeah.
You know about anything. You know about the medications, this weird symptom that they have, which is super valuable for patients, just to have that access to you.
And then your ability to prescribe as you need to. That's been fun.
I think it's been a great experience, and I think it's only going to get better.
Mm-hmm.
I think once the word gets out that there's a provider that can care for, and I'm family nurse practitioner, right? So I can take care of peds all the way up through adulthood. So the ease of getting into me is, I think, a drawing point where, I tried making an appointment with a specialist the other day, and they told me I could get in March.
Yeah.
I'm like, March?
At least June.
Next year?
No, I mean,
or July.
Not 2026. Yeah.
Yeah, and then I've been told by numerous patients they call their primary care provider and they're 4 or 6 months out.
Mm-hmm. Well, we've had some cardiovascular patients come in visually agitated, and we asked, he said, I'm going to see my doc, and I was like, when? And they're like, 2 months from now. I'm like, no, this is now, not a 2-month issue.
This is a now problem, not a 2-month.
But to answer your question, Richie, like, why'd we do this? I think it's kind of been our long-term vision is to have a multidisciplinary practice, with adding, Sue, who's been on our podcast before, and then Chad. It just kind of worked out. Just the timing of all of it was really nice. And we'll keep evolving, but to have, yes, we will find a PT. Okay? We get it.
It's on my brain. It's on my brain.
We need a PT.
Need a different space, maybe.
Which would be great, too, but just keep adding. Keep adding the right people. That's the biggest thing.
Yeah.
Get the right people in here, not just have people just to fill rooms, but get people that hey, it's a cohesive clinic that people can get all their needs met.
And that's another reason why I like you guys is because you want the right people in here, right? Like,
no dweebs.
We could go out and find a PT today, right?
Yeah.
But you guys know just from listening to me, there's a handful of people that I trust in the medical community where I refer people to, right? Like there's a couple at
Which is also
TCO,
a
there's
huge
a couple
value.
here. Yeah.
I was just talking to a patient that has seen you. They're like, oh man, he just got me in with that provider, and like just your accessibility to other providers is super valuable.
Yeah, no, and I think it helps out getting people into these specialty services, right? Like, for instance, one of the guys I know at Minneapolis Heart Institute, which is Abbott Northwestern, you're not getting in until January or something, and I was able to get 2 patients in within 2 weeks. So having those people in your back pocket and knowing that when they go there, they're going to get the best care that is out there. It's not going to be mediocre. It's not going to be a 15-minute visit. It's going to be 45 minutes to an hour of comprehensive care exams.
And now we're not getting as much crap from imaging places too. You know, if we need an MRI.
Which historically was a challenge.
Sometimes when you ask for MRI and they say, no, they need an x-ray before. But if it's from a nurse practitioner, they go, okay.
Well, and Mitch and I even ran into that with a particular patient. They're like, insurance denied it because the order's coming from a chiropractor. And then I ordered it and it was done immediately. So there's some of that too. But slowly over time, I'm going to buy more equipment too, and I can do more and more labs and different things right here.
What are your offerings right now, and what are you thinking of expanding to?
Yeah, so any primary care issue I can handle. I have the availability to do, urine testing to make sure, if someone has a UTI. I have ultrasound where I can ultrasound pretty much any part of the body, including very limited, but you can do, heart echoes with it.
And lung scans too?
Lung scans for pneumonia, or just making sure that there's lung slide there.
Because what I learned with my pneumonia, got to know if there's certain things in the lungs before prescribing.
Yes.
Or else you can rev things up.
You make things worse. I have a 12-lead EKG, and I'm very passionate about doing that on everybody, because you can find arrhythmias, you can find electrical abnormalities that you can fix before they become an issue.
Specifically kiddos in
Especially
sports.
kiddos with Brugada and different types of things that could potentially kill them when they're on the sports field. And then I have medications and the background and knowledge and skill to do joint injections as well. And they've been very successful, the ones that I've done so far.
He's very skilled.
And
injector.
Yeah. It was funny, I did an injection the other day, and the lady had her eyes closed, and she's like, "Are you done yet?" And I'm like, "I already did it. I've already thrown the needle away." She's like, "No way."
How do you balance people that would be coming to a chiropractor, have a traditional idea what a chiropractor is, and is maybe the traditional thought being like, you're anti-injections, you're anti-blah, blah, blah. You guys aren't really anti-anything, I would say. There are obviously some things, but you've always been really open, like, hey, if it's the thing that you need, then that's the thing. This is the starting point. We go, so is there any organization in your brains you have to make to say, yes, this is the time for the injection, and this is why one of the reasons we have Chad here.
Yeah, for me, I'm learning, the more you're here, I'm learning which cases are going to respond best to an injection, or, obviously, better too, but yeah, with the services, with SoftWave especially, SoftWave can help a lot of cases, but if there's cases that don't respond within a couple sessions, it's I would probably refer that patient to go try something else anyways. Chad's right down the hall. He does a steroid injection that can just calm that down. They're better. So, there's a time and place for everything, obviously. It just gives more options for patients too. If they want to go a conservative route, or if they don't want to do injections or medication, great, we have the tools for that. Some people are just I got a biking trip in Denmark in a week and I can't walk on my knee. Okay, you should probably just get a steroid injection so that you can do those things. So it's goal dependent too, with each patient, what their timeline is, all those factors. So but with Chad being here, I'm learning more and more about which route, like which way to triage. Do we do conservative or do we do both?
Yeah. No, and I think Mitch and Zach know too that I'm not a pill pusher or here's a medication, see you later.
I like triple cream.
This is where we
Yeah.
dub in Dumb and Dumber. Pills are good.
Pills are good.
Pills are good.
Pills are good.
That's our joke. I don't think many patients understand that.
No.
Yes.
When I say pills are good, and they kind of look at me like,
Okay.
"That's a nice guy."
he's a nice guy. No, so I also am very conservative on who I put, on medications, and I look at their whole medical history, what meds have worked, what haven't, and one of the things that I'm doing is pharmacogenetic testing. So
Nice pitch.
Yes.
through the
Tell us what that means, Chad.
through the company called One Ohm that was actually developed in Minnesota and is just in the East Metro. They do pharmacogenetics testing where I swab your cheek, I send it in, and it will literally tell me how you metabolize medications, how you break down medications. Are you going to metabolize them very slowly and need a smaller dose? Or are you a rapid metabolizer and you metabolize them so quickly that you need a higher dose? Or do we need to switch the drug to a totally different drug? I've had many acute findings of the patients that I've swabbed so far, and we're able to switch medications, and people are feeling a lot better.
And this is a fairly inexpensive procedure that the clinic overall is trending to recommend to more and more people.
Everyone. If you're ever gonna take medication, you should get one.
Or be in a emergency
Yeah.
I
scenario.
think I just told a patient today, I honestly believe as a medical provider that it's criminal. If you're prescribing medications to patients, why haven't you done this test on everybody?
For sure.
We're not looking at DNA to figure out what diseases you're having. We're not selling it to the government. We literally look at your CYP 450 isoenzymes on how you break down medications.
And that's a liver enzyme?
It's a liver, yep. And so it's super important for anti-inflammatories, antibiotics, NSAIDs, narcotics, chemo medications. The list goes on and on.
Does it do caffeine and other...
You can look at caffeine. You can look at metabolizing folic acid. And
she
if
was very happy, by the way. I talked to her.
Yep. If you don't metabolize folic acid, you can have ADD, ADHD. Your B complex vitamins will be low, which will contribute to weight gain, low energy, brain fog, depression, just all kinds of stuff. So again, I think it's criminal that we don't do this on every patient. So every patient that I see, I'm suggesting we do this. Mm-hmm. I think I'm one of probably only a few providers in the whole metro area that are doing this. This is a huge practice at Mayo Clinic. They're One Ohm's number one client.
Mm-hmm. We're number two.
I think I'm going to be number two very, very fast, honestly, because I'm just going to do it on everybody.
And because how many people, any of you three see that have a more than one medication they might be taking, or one supplement, right?
Well,
like everybody has.
I think about emergency settings for like parents and their kids or someone who's never been on something and then they're suggested to be on this, like a dad having a heart attack and being on a statin. It's like, well, I can't be on this one because I have my One Ohm test that suggests otherwise. Mm-hmm. So I think it's going to be, maybe we just provide it as a service, explain it to people. They can deny it. They don't have to do it. But I think just having it with your medical chart
Well, and I think it should be talked about. If you have this particular test at a very specific institution, they charge $2,000 to do this test. Mm-hmm. I charge $0, right? Because I want the knowledge. I want to be able to scan this to people's charts. And then before I prescribe a med, I can pull it up and say, oh, they can't metabolize this medication, or they metabolize it differently so that it's going to cause huge side effects, or they're going to have problems with this.
Well, the psychiatric drug test, the one that shan't be named, but that's why they've developed it, because some kids had such a hard time with certain psych drugs.
They looked at kids that had ADD or ADHD, and they were putting them on medications, and they were still having side effects and issues. So this test was designed initially for psychiatric medications, and they found that a vast majority of people were on meds that they didn't even metabolize the right way.
So it made them feel like garbage.
So it
and
made them feel like
compliance is
garbage. Yeah, and that's huge, right? Medication compliance. If you're going to put someone on an antidepressant or something, or a statin, you want to know if they're going to have side effects, right?
Will that help with like a statin-induced...
myositis?
Yeah.
Yes, it does, because it'll show statins in the cautionary category, and then it'll show in the green category where the patients, can safely take those in a least amount of side effects.
Because that connection with our practice is that you'll have people coming in with like multi-joint pain or soreness. You kind of work on them for a while, and if they're not responding, that's kind of a trigger for me to ask, like, are you doing any statin type of therapy? And we had a patient who had some of that going on. My dad had it with his heart.
And this is such a big problem that Mayo Clinic has an entire department for statin therapy. That's how many people have side effects. They have a whole clinic, a statin clinic,
Right.
where all they do is prescribe statins and switch statins to help
And that's
people.
a perpetual drug too. People get on that; they're not told to get off. Or
Right. People get on it and they just
So-
stay on it forever.
yeah, time goes by, and then they are like, I can't even lift my shoulder over my head, and there was no particular injury. It's because it's a muscle tendon stiffening. Is that what a statin? What's the mechanism of that?
So you just get a lot of muscle soreness, and you can get muscle breakdown to the point where people have had rhabdo from statins, right? There's case studies that you can go read about where people couldn't even get out of bed. They couldn't move.
Rhabdo's when your muscle breaks down and your
Muscle
kidneys
breaks
can't.
down, and your kidneys can't excrete all the breakdown. So I think I'm offering a lot of services that you wouldn't see a lot of clinics or nurse practitioners. For instance, and obviously we can't say patients' names or anything like that, but
Bill Brasky.
I've had two patients in here that have seen multiple providers throughout the whole metro area, and I'm the first one that they came to and said, well, now we have answers. Like, why didn't anybody else do this? And
Right.
that's what I can't wrap my brain around why, if you're a prescriber, well, this should be like a requirement. You should have to have this test before you get prescribed a medication.
Well, and then that poor patient on 46 medications at one time.
Oh yeah, 46
5 different
medications.
prescribers.
5 different prescribers,
How many?
and you're taking a med that is causing a side effect, so you're taking a med to cover that side effect, which is giving you another side effect. So they just kept
And the
piling on.
pharmacist can't say boo to that, right?
No,
Like,
so
here's your bag of pills.
so pharmacists can, if they talk to a provider, they can say,
Pills are good.
Do you want some?
yeah, pills are good. They could say, hey, that dose is probably not appropriate, or they can whatever.
Do they communicate that to the patient or the provider?
Sometimes the provider, if you call them, but you got to remember, 90% of meds now are e-prescribed. They don't
Yeah.
talk to anybody. Oh, a guy came in and he was on 20 different medications, and he was actually taking 2 medications that if you combine them together, they could kill you. And I said, you're taking these 2 together? And he goes, yeah. Is that why I feel dizzy and like I'm gonna pass out? And I'm like, yeah. So that got past an MD and also a pharmacist, right? And then I listened to his heart, and I'm like, have you ever been told that you have an aortic murmur? Yeah, they may have said something about that. Well, that guy's now going to have heart surgery.
Yeah.
So, like,
Wow.
his aortic valve was
Toasted.
severely damaged. So, there's a lot of mismanagement, a lot of misdiagnosis going on, and then just the polypharmacy, right? If you're over the age of 60, 65, and you're on 5 or 7 meds now, that's polypharmacy. And a lot of times these patients come in, they're on 10, 15 meds, and they're from 2, 3, 4, 5 different providers, and none of those providers are talking to each other. So there's no way that can be safe. But I want to do comprehensive sports physicals where, 1, we do 12-lead EKGs, and 2, these guys do the neck care looking for concussions. 3, we do just a very comprehensive heart and lung assessment, because It was just recent. We had.
I would go down.
No, keep them up.
Nope. This is a sad story, so we gotta be
okay.
serious
Okay.
now.
It was just recent. There
Yeah.
was
Iowa boy,
a 13-year-old.
Yeah.
He was young. I thought he was 10. But
It might have been even younger. Played, I think it was
baseball tournament.
Got his trophy and died. I mean, he collapsed and went into cardiac arrest. And again, there's people walking around. There's kids walking around right now that probably have, cardiac channelopathies or cardiac cardiomyopathies or different cardiac issues. And nobody's ever assessed them with a 12-lead EKG or anything. So then how do you know?
Yeah.
And so they're playing some sport, and they go down in cardiac arrest, and you hope that someone close by has an AED or something to help them.
Yeah.
But that's not always the case. They're not always readily available. And there have been parents in here that said their last sports physical was kind of a joke.
Yeah.
Nobody listened to heart and lungs. Well, how can you not listen to heart and lungs when you're doing a physical for someone that's going to be playing sports?
Mm-hmm.
Or, how many of those people, even if they listen to heart and lungs, do they know what a murmur is? Do they know what to do with a murmur? Like, probably not.
Mm-hmm.
And so there's a lot of kids that I think things are missed. And then we had a couple of parents, I don't know if it's Mitch and I or Zach and I, but they said they don't even check for hernias anymore.
It'd be my goal for people to feel comfortable, be like, well, let's go see Chad for a medical issue versus going to some random person that we don't know. Because I think the primary physician, like back in the day, you had your doctor in the town and he'd go around and help people out. It's not like we're going to do that, but it's going to fill the gaps a little bit. Mm-hmm.
And I've been a product of medical mistakes myself, and
Look at him.
Yeah, look at me.
Yes.
I've had surgeries that weren't needed. I've had surgeries that were botched. That they're supposed to fix one nerve and they cut a different nerve.
That
and
hair
you have
transplant
problems.
went really bad.
Yeah, and I even paid extra money to go to Turkey, and this is what I got.
Your ass is quite hairy.
You got ham. You didn't get turkey.
My back is hairy, so.
Should we talk about favorite cases so far? I think we have a handful, but just like specific in.
We've had some really good.
I think
outcomes.
We had a patient who was referred here, who was dealing with some mid back pain, just kind of coming in for a tune-up, and that was successful, and he was happy with it. But through my discovery with him, I kind of picked up he was dealing with some melancholy, and so I talked to him, about it a couple times, and then you came up in some facility, and I was like, maybe you should talk to, because I can't remember if he was taking any medications for it.
No, yeah. So we've had really good outcomes with certain patients that, one, I think were just mismanaged other places, but then two, just didn't know what type of help that was even out there or what type of stuff they should even do.
Yeah.
And so we've had really good outcomes with a lot of this stuff.
Us as chiropractors can't really handle it. It's not in our scope nor our business to be doing that, but it's nice to have East meets West.
East meets West, yeah. What I was thinking is like if this was a job posting for a PT, what is it that this is a compliment opportunity for the three of you. What is it
if
that
you want to work at a place that has no HR?
Wild West?
Yeah, you can say whatever you want.
Questionable.
Don't be offended.
Yeah,
Or
you
be
can't,
offended.
can't be easily
Be
offended.
Be offended.
Then come here.
Then we're your guys.
Well,
No.
what are the characteristics you guys saw in Chad and that you wanted to bring into Midwest Chiropractic and then vice versa? Why did you come and say, yeah, this is perfect? Because I think that gives patients a really good idea of what the vibe here really is like.
I think a large part of it is, number one, he cares. Like, he truly wants to help people. I think maybe,
Rebel
I think
at
another
heart.
part,
Yeah.
and I don't know if we've ever said this out loud, but thinking about it, but like, they got to be chiro friendly.
Yeah.
Chad understands. He's seen us as a patient, right? It's not like we had to convince him, like, hey, what we do is valuable. Like, he's already in. So that's
No, so I bought.
Yeah.
I mean, it's not that I had to buy in or anything. When Mitch was joking around, like, hey, you should come here. Initially, I was like, I don't know if I'll ever leave the hospital setting.
Yeah.
Because I was just so intertwined in that environment that's all I've done, right? And so at first I was like, yeah, no, in my head. But then after a while I'm like, like,
Well,
maybe I should do this.
There was some pissing off opportunities there too.
Yeah, there was. Yeah.
Well, it's just like, and from like person to person, just seeing Chad as like this rock star clinician, surgical, you know, it's like your open heart surgery. That's like, to me, kind of like, it's pretty difficult. I mean, I've seen hearts in cadavers and, you know, studied deer guts every once in a while, but
if you're a surgical first assist, or if you're in the operating room and you're doing procedures and whatever, you don't always get the thank you, the whatever. It's kind of a thankless position, right? So how long are you going to do that for, right? Where you don't, it's a thankless position and yet you're doing all the work, right? Like, you open the case, close the case, you're putting all the sutures in, you're doing all the stuff, and then you're seeing the patient on the floor and no one cares. Right? Like, I think we all eventually, I think, run into that wall where you're like, yeah, I can't do this anymore. And I'll tell you, to be totally honest with everybody in the room and listening, like, my wife told me at one point, she's like, you're a very unhappy man. Like, she's like, and my wife obviously is my biggest supporter, and she's like, you're a medical genius, but something is bothering you with these jobs that you're doing, and you need to figure it out. Because I mean, I was bringing it home, right? And now lately, she's like, you're the happiest guy. She actually called him to get home. Right? And we're in our room. He's like, oh crap, Carla's calling. What do you want? Come home. And Mitch is like, you should probably go home. You should probably go home. So everything's changed, right? Like, where I've told both these guys right here, I told them thanks for the opportunity, and I really meant that, because it got me out of a very bad place that I was in my head and everywhere, just with things I was doing. Yeah. I didn't know it at the point, or at the time, but like, doing surgery, being in the operating room, you know, standing there for hours, doing all that stuff was taking a toll on not only my body, but also my psyche. Yeah. Because I've done trauma surgery, neurosurgery, spine. You know, I've done all of those things. It's all boring. Nobody wants to be here. Yeah.
How would you guys individually describe, like, what a patient can experience now, what that difference is? What's this evolution of where the clinic is going?
More personalized care.
No, I agree. It's totally individualized care. Yeah. Because you're going to see Dr. Mitch or Dr. Zach. They're going to give you the time that you deserve for your adjustments and things. If you have a medical need, you're going to see me, and I'm going to spend at least, bare minimum, a half hour with you. And that's at follow-up appointments, right? There's been times, awkwardly, where patients are just sitting there, like, looking at me like, what's next? I'm done. Like, because I'm spending that much time, and I'm really, I think patients should know that they're going to get individualized care and evidence-based care, right? I'm not going to do stuff off the cuff. It's going to be backed up by science and evidence.
How has it affected yet, or have you noticed how it's affected the way you guys see patients, knowing that Chad's just down the hall now?
I think it's like an ace in my pocket a little bit.
Sure.
You know, and then I think it's just nice too, because some patients don't have time for chiro care, and that's always going to be a thing. And qualifying a patient, you know, if we do an assessment, we're like, okay, this can help, but you don't have the bandwidth to manage it, go see Chad. The urgent care setting in orthopedic clinics is freaking awful. Like, garbage fire. We send people to, I almost said it, to urgent care facilities. And I've had 2 patients that were told that they were just drug seekers. Wow. From my recommendation going to urgent care.
Which is awful.
And that pissed me off to a point where we were kind of done with them, but you know, we're salvaging some things.
You know, it's always wrapped around money, right? And they want these patients to do tests that are just not needed, and it's just a money capture.
X-ray, MRI stuff is absolute.
If you're getting an MRI, you don't need an X-ray.
East meets West.
Yep.
Mortal Kombat style.
Meets West.
Yeah. Is that the right way?
No, it's like this.
Ooh, put those down.
I'll blur it out. Yeah.
Well, That's
That
a
was
wrap.
good.
On the
Perfect.
Tap.
Thanks for listening, everyone.
This is a house of learned doctors. You're not a doctor.